very welcome back to the show. Now, winter can be a particularly challenging time for so many people living with painful chronic conditions.
Yes, so what are the different ways to manage long-term pain? Dr. Dominic Hegarty, a consultant in pain management, is here to offer some advice. Welcome along to the show. So what exactly is chronic pain? Because we hear it a lot.
We do, and unfortunately it's a term that has a timeline on it. So officially, if you have 3 months of a pain that's there on a daily basis, that reaches chronic pain level. Different from acute pain when you sprain your ankle and it goes away after a couple of days. But 12 weeks doesn't be long coming around, but it's a long time to be in pain, and officially that's when it transfers over to be chronic.
Dominic, can you define pain then as well? Because I remember chatting to you before about pain. We see pain as pain, but you don't see pain as simply pain.
No, that's a good question, because pain varies so much, and it's the style or the type of pain. So when an individual comes to me and for a chat, I'm listening. How are they describing the pain? Are they describing it as pins and needles or burning pain? That reflects kind of neuropathic pain. Pain that's stuck in the nerves. If it's a swelling and a hot and cold sensation, that's inflammatory. There are two different styles of pain, but to you on the street it's pain, but you need to deal with it a different way, and how the individual copes with that pain is different. And of course it opens up the avenue, which medication or which intervention you want to go totally changes with that aspect. So first thing is listening to how the patient describes it. They're the best candidate to help me help them, which is interesting.
Yeah, and like you see a lot of people with chronic neck pain, don't you?
Yes, it's a big thing. We all think of low back pain and we think of sciatica and the guy who pulled his disc, but neck is a big issue. About 30% of people who come to a pain clinic come with neck pain. Now, what do I mean by neck? It's everywhere from, like my friend here, from the back of the neck, from the skull, right down until the shoulder area itself, and out into the arm. So
that's all neck pain?
That'll be all regarded as a source of neck pain itself. So people think it's their shoulder, but in fact it might be their neck and vice versa. And that opens up a whole gamut of problems.
What's causing it? Is it something that happened in an accident or something, or is it lifestyle? Is it stress?
Actually, it's a little bit of all of those in a funny way. We know there's a certain population. Usually, unfortunately, if you're over 40, you're at a better risk. If you're a lady, you're at a higher risk of it. But usually an issue of occupation sometimes puts it at risk. In the past, we thought of fellas painting ceilings and decorators. Now you can be at your computer and you can have a repetitive low injury thing, particularly if you're moving from desk to desk, different computers. You're not set up properly for it, so our posture changes.
I was going to say that I would often kind of get sore around my neck, and it's just from being on the laptop.
Absolutely, and you're looking at your iPads in front of us and you're twisting and turning all the time. But it's a big hit, and people begin to pick up on it quickly, and simple things like being able to turn and look out the side mirror in their car becomes a big ordeal, and they literally have to shift their whole body around to get
I'd imagine the longer you leave it, the more problematic it's going to be down the road.
It is definitely. I mean, that's the one thing, particularly around neck pain. I think the guidelines people say to me is, how long should I leave it? I say, if things aren't settling down with standard treatment in with about 6 weeks, it's time to sit up and listen to it. Any longer than that, you're beginning to progressively get worse. And I know that's a long way away from chronic pain in 3-month window, but people with neck pain, they really want to get it sorted. It takes them out of their job, their lifestyle around the house is in trouble. Simple things like getting the cupboards and emptying things around the house are a real problem for
people. And getting dressed, all that kind of stuff as
absolutely,
well. And so what kind of treatment plan then would you put in place for people dealing with the neck issues?
Nick, I suppose there's two. The first thing is the conservative, starting with some anti-inflammatories, gels, maybe a little bit of physio work, and it really does help in the first element. About 60% of people will settle down with that kind of a strategy, usually within the first 10 or 14 days. When it goes on, my alarm bells start ringing, and that's where the history comes in. How are they describing it? And I'm looking for, in the back of the skull here, you can see you're looking at a couple of different areas. You're looking at either the muscles or perhaps even the joints, the facet joints, the disc tissues themselves. And I know for example, it's a really complex area. Lots of things are going on at the same time, but you're looking for the source of it, and we can do MRIs and X-rays to try and target that for people.
So even though you may have a pain in your neck, that mightn't be where the problem is. Is it fair to say that?
It could. Well, yes, it is. Yes, is one way. It may be the neck. That's the first thing itself. But you might present with hand pain or a symptom that's running into your hand, and you're feeling a heaviness in your arm. That's an issue. People might come into me and say, you know, Dominic, I feel my head is too heavy for me, and it's the heaviness is enough, and you start looking at what's going on. This guy is about 4.5 kilos, it's about 10 pounds, sitting on a very narrow stock. That's about a real life-size skull size. So it's a lot of weight going down on those facet areas, and the minute there's a bit of wear and tear, things start acting
But if one thing gets out of line, I'd imagine it knocks other things out of line as well.
Exactly,
certainly, absolutely. And the compensatory element comes into it immediately.
Yeah, you brought to us an X-ray, and you might be able to explain this one for us, Dominic.
Absolutely, I think they have it on style. You can see, hopefully we'll have the image up on it. the good thing, that's just looking in straight in from the back of a person's head, if you like, and that little black line towards the end of it, that would be what we call a needle approach to target where the nerves may be coming from and where the disc tissue is. So that would be a shot I would take under X-ray, identify where the area is with the individual and inject some local anaesthetic, some steroid to it to try and alleviate the symptoms and very focused. That needle in particular has a technique called a Racz procedure, which is a way you can advance a very fine wire up under X-ray guidance. So it's not a sharp edge, it takes the risk away from patients, it gives them a bit of comfort, and they'd be chatting to me as I'm doing this, and I'd be saying, well, is this where your pain is? And say, yes, it represents it. That's our target. We focus on that area. So it's really working live in action with the individual, and that's the way I prefer doing it. It's much, much easier.
Dominic, you've been dealing with these cases for the last 12 years. You must have seen it all, have you?
You never say that, you know. You never say that, but every time there's some new angle on it, so you keep listening, and the patients are always teaching me new ways of finding pain and hopefully getting rid of it too. But that's a different question.
We have a few questions for you here. This person says, I have osteoarthritis and I've been recently diagnosed with fibromyalgia, and this person has attended a pain clinic and is on medication. The medication, they can't drive or go to work because of the medication. And this person, I suppose, like lots of people, Dominic, who have chronic pain and who have been suffering for a long time, they're worried about the long-term effects of the medication.
Yeah, no, absolutely. And taking that as an example of answering that question, certainly it is. And while you don't want to put alarm bells up on people being on medication, many people are on medication because they need it, is the bottom line. But sometimes the dose might be a little bit wrong, or the combinations that they're using it might be a little bit wrong. And in that individual who's having difficulty driving, for example, I'd be looking at what products there are. Maybe they've got a bit too much of it going.
So the dosage is too strong?
Dosages might be a bit in excess, or the timing of how they're using the medication might be a little bit. And often a chat with their GP can sort out a lot of that very quickly itself. And sometimes over time pain changes. So you mightn't need quite as much after the treatment is succeeded.
Fibromyalgia is something that we seem to hear a lot about lately.
Yeah, absolutely. We discussed that here, one of the other shows we had on, and it's a real catch-all phrase because it really is affecting a lot of people. It's, for those people who haven't heard it, it's muscular pain all over the body, 4 or 5 zones within the area at the same time. It's a diagnosis of exclusion. So we've ruled out everything else.
So
it's a bit of a hard
test
thing.
for it.
There's no test for it, but the response is a little bit of medication. The one thing about it is activity does really help it. It kind of gets the blood flow to the muscle going. So it's one where we encourage people to keep going, and the confidence to keep going is important.
Because it is very hard to diagnose, doctor. I know certain people who have it, and when they go speaking to their doctors first, people don't believe them because from the outside they look perfect, they look fine and everything, but that is not the case on the inside.
Absolutely. I mean, that is probably the biggest killer. If you listen to clients who come into me and individuals, no one believes them. And that's their biggest fear. And very just giving them an ear of saying, listen, I'm hearing what you're saying. Let's try and make sense of it. That lifts a burden off people. That's the first thing. Because you're quite right. You can walk down the street and it doesn't know. You must remember 1 in 5 individuals have got chronic pain.
That's incredible. That's a lot of people, isn't it?
20%.
It really is.
I mean, if we did a quick survey around the studio here, I can tell you there's a few people out there already who has.
They're probably asking you plenty of questions as well.
We have a few consults already on the screen.
To the side all the time when it comes in.
We've got one more question here as well. I have arthritis in my shoulder, which at times gets very sore, and I'm unable to raise it. So what is the best cure for this? Are nerve blocks any help?
Well, without even taking it any further, what strikes me straight away is I'm looking for a thing called bursitis, which is inflammation just on that history. And if you can't raise your arm, and if I can demonstrate, if you can't go above this level, you're getting caught because you're getting trapped just at the tip end.
Is it a trapped nerve? Or
it's a trapped collection of fluid. A burst is like a little oil pocket, but it's got hardened and firm, and it stops you working. A very simple injection to that area can free up the whole area very quickly. Now, it may not be this individual's issue, but it's simple things like that, picking up on what they can and can't do with clinical listening to the story is very important to them.
And your mantra, doctor, as well, is put people on medication, but you want to take them off the medication as time goes by.
That's my ultimate goal, and that's where interventions come in as great tools for me. I mean, 9 out of 10 people will come to me. There's an approach, an interventional approach that's going to match up what they need generally. And the goal is to start the ball rolling, use the medication as tools, and that's the word I always use to patients, to try and reduce the scenario. And that gives confidence to people, because I know people come in and the last thing they want is another box of sweets going home in this tablet. There's enough of that going on, but it's using them properly, using them with a strategy is really what you try and do and try to help them. And people buy into that really, really quickly, and that's fantastic. I mean, from my point of view, that's what I want. I want someone's going to work with me.
And I suppose over Christmas as well, listen, we're all visiting, we're going around, we may leave our medication behind us and so on and so forth. That shouldn't happen.
It shouldn't. It shouldn't. If there's one thing over the season that's in it for all your viewers and work it through, is try and stick to your routine. Keep as rigid as you possibly can. And we know it. You're going to be up in the morning early. Santa's arriving. All kinds of things happen. But you know, stick to a routine. If your usual is to sit down for half an hour and get a bit of rest mid-afternoon, do it. Stick to it. Get to sleep. Get the bed pattern right.
Yes.
It's wonderful. So look, hopefully the viewers and yourselves have a lovely, lovely Christmas season.
Same to you, Dominic. Great to have you.
Thank
as
you
always.
Nice to
so
be back
much.
in.
Thank you
Thank
very
you very
much
much.
indeed. Now, if you're looking for more information on anything discussed today, please head over to our Facebook page, RTÉ Today. And of course, if you have any medical conditions, always consult your GP.